Good evening. This is Roberto Carta of Kirsten Dental, and I'd like to welcome you back to the Implantology Talks, a series of interviews with some amazing digital dental masters. I'd like to start with a short thank you to our audience once again for the amazing response to last night's interview to Dr. Jafar Mui. If you missed it or if you wish to review it, please be reminded that the videos are available for 2 days. To watch the other interviews or to get notified for the other sessions, please register to the link in the overlay window that you can see now. With that, let's get started. I can see that our guest joined us. Hi, Miguel. How are you tonight?
Hi, Roberto. Doing fantastic. Really excited for another amazing interview. How exciting was last night?
Indeed. Yesterday was another fantastic, inspiring interview. This evening, you will discuss about digital technologies and bone regeneration. We're ready for it.
Really excited. Yeah. Not just that, I mean, we started in the north of Africa, now we go all the way to the south of Africa, covering the entire continent.
That's very exciting. So, Miguel, over to you to introduce your guest tonight.
Well, our next guest, first of all, it's an amazing honor. For those of you that don't know, I was also born in South Africa, and my next guest, Professor Howard Gluckman, is a world-renowned educator, a speaker. He has a full-time practice in Cape Town, and he's the director of the Implant and Aesthetic Academy, which does postgraduate training locally and also online. And I would say, without a doubt, one of the world's most foremost experts in three-dimensional autologous bone reconstruction, with a particular gift for harvesting from the palate. If you've ever seen him on stage, you'll know his electrifying stage presence, backed by awesome cases and just a deep knowledge of science. But I guess one of the, and I don't mean to embarrass you, Howie, your humanity, your deep gift for caring for your patients is unparalleled, and that's why you are widely accepted as one of the best and the greatest educators in the world today. It's my distinct pleasure to welcome you today, my friend. How you doing?
Miguel, hi, how are you? To everybody, Roberto, to everybody there, thank you very much for having me. It's an honor and a pleasure and a privilege to be with you here, my dear friend, and thank you for the kindest words. I think my mother probably couldn't have written a nicer intro, but yes, a little embarrassing, but thank you so much for the kind words, and thank you for having me. It's an absolute pleasure to be here, especially amongst the other speakers that you've had who are just, you know, I rate amongst the best in the world, and just a pleasure to be with. So thank you for having me. It's an honor.
Well, you know, I think Carestream, they've really done an amazing job over the last years of just weaponizing extraordinary clinics. And I think it's wonderful that we get a chance to talk about this. But I wanted to start today by embarrassing you a little bit more, because I know you don't like talking that much about yourself, and you're quite discreet about this. But if you know, if you asked me to introduce you and your work, what would you like me to say? How would you describe, you know, who is Howie Gluckman? What is it you do, in your own words?
Look, I mean, it doesn't require a lot of words. I think from my side, to you know, there's the only thing that I ever want to be known as is honest. I want to be known as real and honest, and I think that sums up everything that I do, from the research that we do, to the cases that we show, to the lectures that we give, and everything that I try and do with honesty and humility. And I think that's the most important thing, more than anything else in the world. And if I achieve nothing else other than that, then I'll be very happy with a legacy like that. I think in this day and age, there's just too much fake news, maybe for a bad choice of words, but there's too much. I don't want to use bad words, but it's just like there's just too much nonsense going on, and I think it's important for us to stand back and show reality and show failure and show where things have not worked. I think it's more important to show that, because I think that tells a story more importantly than showing the success that we see so beautifully around the world. But you know, the success is always tainted with with multiple failures to get to that success. And sometimes better to see the failures, you learn more.
You know, do you think that what we do, you know, I'm a big fan of bone reconstruction. I've been a surgeon myself for 20 years now, and I've seen your work, and you pull out some really challenging cases, and always backed by science, which is something I love about your work. But do you think that implicitly the kind of work that we do forces us to be honest, because we have to deal with failure every day, and the only way you deal with failure is by being absolutely honest?
I actually think it's quite the opposite. I think people have got not everybody, and then it's maybe too much of a broad statement, but there's certainly, I think, you know, there are many fantastic surgeons who have multiple abilities to do multiple different types of treatments, and those people certainly have the skill set and the mindset and the ability to chop and change and turn left. And I think those are the people that are the honest ones. I think I've said this in many lectures, you probably heard it, all you have is a hammer, everything looks like a nail. And I think as long as it looks like a nail, you will justify your results, and you will, you know what I mean, when it comes down to harvesting, you know, harvesting the money or wallet biopsy, you know what I mean, if all you're about is doing a wallet biopsy, then essentially you will justify your technique, even if you don't look at it. You know, when you're drilling into a bone graft that hasn't worked and the whole bone graft is moving, you know what I mean, and you say to yourself, yeah, no, it just needs more time, it's gonna form bone eventually, and on the x-ray you've got this wonderful white material that looks like bone, but in your heart you know it's mush, it's not bone, it's never gonna become bone. I think, you know, I hope people are, you know what I mean, but the problem does come down to the fact that when people stand on the stage and they pontificate about specific techniques that work everywhere, and even autogenous bone is not for every single case. You know, you have to choose the right case for the right moment. I think, you know, but you realize that if things don't work in every case, don't keep using it. It's just crazy, and it's not fair to our patients.
Yeah, I'd agree with that. And, you know, what would you say is the greatest lesson that you've learned just in the last 2 years as a clinician? Like from from a clinical perspective, from a human perspective, what are some of the greatest lessons you've learned recently?
Sure, I'll tell you, if I can tell you, you know, it's crazy. I mean, you know, you and I have been on the lecture circuit for a long time together, a lot of the times, and being on the lecture circuit, you very seldom get a chance to learn. I mean, you learn from your colleagues and you pick up stuff in the lectures and things like that, but when last did you do a course? When last did you actually physically sit down and do a course? And I have to say, I did the DSD residency online during lockdown with Christian Coachman, and it absolutely blew me out of the water. I have never been so excited about going back to my practice, and all the stuff that I learned in this was simply sensational. And I've learned a lot of stuff from a lot of people, but I have to say that was, in the last 10 years, probably the best course I've ever done, and I can highly recommend. And I've been in practice 30 years. I've been a specialist since 1998, which is probably more than most of the youngsters out there, or you know, and still it blew me away. It was absolutely sensational. So what did I learn? I went back to my practice and I learned about making my patient feel even more special, because I thought I was making them feel special. But the response that I'm getting these days to implementing a lot of the concepts that Christian put across to us, I mean, I'm getting feedback and letters and bottles of wine like I've never received in my life before. So from that point of view, it really was just, it's just been an awesome experience, an awesome thing. And my staff love it. That's the key factor. My staff are so happy. They're enjoying it. They're sitting there. They're part of a team. They're expressing, we're talking with the patient. It's wonderful.
It's incredible. You know, I think that's one of the greatest lessons that we should teach the younger generations, have that humility and that openness to always learn, and to go down roads you usually wouldn't go to, and to just like let go of your ego and just always be open to learn. And Christian, of course, the DSD, it's an amazing platform for connecting and engaging with your patients. But how would you apply that, you know, seeing that most people would connect your practice to surgery, but I think a lot of people don't know that you also work a lot with the restorative aspects. So
Well,
how do you divide your time?
Well, you must understand, I am a surgeon by nature. I'm a periodontist, although I think I'm more a hybrid oral surgeon periodontist. I think I've kind of morphed into that. But you must understand that I've always done all my provisionalizations from full arch to thing. I've always done them. I do not let anybody touch that stuff, whether they're a specialist prosthodontist or whatever. I don't care. If I'm going to load those implants and I have to treat the failed implants, I'd rather do that. So I've always taught myself all those skill sets, so the key factor is, and I think the DSD is such an important part, and you'll see in the case that we show, you have to understand how everything fits into the face before you can even start your surgery. And I think the DSD, the DS course reiterated that I was involved with DSD, but never to the level that I am now. And certainly that has become, it's just moved everything more front and center than it was before. It was just part of the workflow. Now it's really front and center, and the teams that we have around us, and the groups and the specialists and things. It's just awesome. It's just taken everything from. I always thought that we worked at a high level, but now we work, I think, at the top level.
I know it's a lot of fun, and obviously without all of the digital technologies, your CBCT, your iOS scanner, you don't get access to any of that. And I think that that's something that we will get a chance to talk about later, the importance of all of this technology, not just from a clinical level, but a diagnostic level and patient communication level. Now let's pivot to, how did you deal with this, with the pandemic since March? How volatile has the market been? Did you see a growth of your online education on your academy? I've seen you very active on social media. And also feel free to talk a little bit about what was it like to spend so much time at home, meaning in the clinic, not traveling so much.
I think, it's crazy because like you, I was away between once and twice a month, and being away from South Africa means a week. It doesn't mean, everywhere is far. But being at home, I thought I was going to go nuts, but it was an insanely beautiful reconnection with my kids. Not reconnection, but just like time spent with my kids and my wife and the whole family, and just like, playing chess, playing board games, swimming, just doing crazy things that, when last did you, our break was about 6 to 7 weeks, and when last did you have that break? I have no recollection of ever in my life, not since a student, have I ever had 7 weeks of holiday. So that was really special on an interpersonal level. It was really cool. But obviously we got back to work after about 7 weeks, because in South Africa we had very severe lockdowns right in the beginning, which seemed to have worked because our levels really have remained, and our death rates has remained low, which is really cool. I think there might be something in the genetics of South Africans as well, or Africans as a whole as well, which is keeping the rates down in Africa. But getting back to work also, the slowdown, and you're an expert of slow dentistry, and I certainly can say I was not doing, when you travel and then you have to come back and keep a practice going, it's difficult to be slow. The patients are piled in, you really got to do a lot of work. And
I was always finding the day I got back, I was like so anxious to get, it's amazing, the being present.
Yeah, so that together with the DSD and slowdowns, and it being able to introduce new protocols in the practice, I realized that I'd lost my mojo. I love what I do, and I've always been absolutely passionate about every case that I do, about sitting there and developing the soft tissue and a little bit of this, and let the patient wait. The next one's waiting, let them wait. This one needs a little bit extra soft tissue here and a little bit of this. But you lose that, and by cutting the patient numbers in half allowed us to regain that. And the funny thing is that when we've gone down to level 1, which is almost back to normal, and my staff started rebooking me that way, and I called them the other day. I said, stop, we're not ever going back. this is the way I want to work. I'm not going back to that, and it doesn't matter if we don't earn as much money, we don't earn as much money. But the great thing is that every procedure that I do, I love, and that's the key.
That's honestly, I just got some goosebumps there, my brother, because you know, that's something that I've been preaching around for a long time, and I would say that one of the keys to success, like cooking or good wine. I know you like good wine. For those that don't know, South Africa actually, where he studied in Stellenbosch, they make some of the best wines in the world. And you know, there's a lot to be said about being very generous with fewer people. So you know, if you have so much to give and you spread that out over a lot of people, people get less. But if you spread that out over fewer people, and at the end of the day, complex cases require a lot of generosity, time, you know, like you said, going back in, doing another temporary, getting that soft tissue perfect, and just being a fanatic. And you reconnect with the art of building beautiful smiles, which you don't get if you're, you know, always on the backlog, because all of it takes is like one thing to go wrong and your whole production line gets messed up. So it's incredible.
Absolutely.
And any new technologies besides, like, did you make any investments besides that? Did you hire new people? Did you let people go? How did you manage your business?
Well, I think, you know, I mean, my nurse has been with me for 25 years. Most of my staff have been with me for between 15 and 20 years. We had one staff member who's been with us for 6 months, and I have to say we all bit the bullet. We cut to the bone where we could, and I kept every single staff member on. And I think, you know, we have to, you know, we are lucky. We are in a lucky position, and I think it's so important that we as owners don't go tossing out the lowest level staff member, who, you must remember, those are the people who struggle from day to day to eat. And all it's going to do for you, if I take home less money, it means that I'm not going to be able to go to a restaurant a couple more times that month. And I think it's so important that we realize that the people, the lowest people in our practices, and a lot of whom have been let go, which I think is disgraceful. I really do. And I think anyone who, you know, you should look at yourself as a human being. These people are struggling just as much as everybody else. So, you know, we took myself and my partners, we cut everything, and we took less, and we managed to hold on to every single one of our staff members. We did reduce salaries a little bit for, say, a month or two, and we managed to get some money back from the government, not a lot, and certainly South Africa is not what you'd call a wonderful example of non-corrupt public service, but we managed to, and I think you know, the staff come back, you know, when they realize, and because their friends are being let go, and they realize that what have we created? We've created loyalty within our staff, which is just so powerful. You cannot buy that loyalty.
You know, ladies and gentlemen, you've now actually seen one of the essences of why, you know, Howie and people at the top really are thinking. And this is something that it's that moral code, Howie. It's just beautiful, and I hope that this is one of the big take-home messages of who's ever watching. You know, that it's the little people, not the little people, but you know, it's the people that sometimes we forget in our ecosystem that are the most important to protect, because, you know, you see a lot of doctors take all the glory, and it's such a team effort. And I think times like now where you really show true character, and I'm very proud to know that a lot of men and women around the world in positions of leadership have had the same initiative and the same mindset that you have, and cutting off the fat, and keeping the muscle, keeping the brain active, because better times will come. What are you, just to sum up this initial round, what are you hoping, what is your instincts telling you when this is going to be over and things are going to come back to normal? What are your insights into what the new normal will be?
Look, I think you know, we are like fish in a pond. You know what I mean? We will forget. We will forget. I think we will forget. There'll certainly be certain things that have changed, and you know, fundamentally we'll continue. I think with the level of PPEs that we are using, I think that will probably remain to some degree, because I think a lot of us have implemented things that are really, it's hard to go back from them because you're feeling so safe with that. But I think once the vaccines come in and they start to take over, I think we'll come back to some semblance of normality. I think the bigger issue really is how the economies are going to be nailed, and I think that's more of a problem than the COVID illness itself, because I think that's going to probably keep with us for the next 5 years.
Yeah,
but I'm only a dentist. I'm not an economist.
Yeah, I fear that there will be some form of economic collapse in terms of, you know, people from the hotel industry, the restaurant business. There's a lot of businesses that are going to take a huge hit in the coming months, and I do think that there's, you know, we just need to stay vigilant and focus on quality more now than ever, because oral health is directly connected to systemic health, and we need to at least make sure we take very good care of those people that come in and look for our help. All right, so I think that's as an introduction is amazing. I'd like to get started with some clinical stuff now, because I know you've got some really interesting stuff to show us, and really excited to see how you've connected the digital workflow into your diagnostics, your treatment planning, and also your follow-ups. And let's get into that. So Howie, we've got a bunch of technical questions for you, and the first one is, you know, bone regeneration techniques are highly documented and very scientifically documented. Which of these procedures can now be performed through digital workflow?
I think the question is, which of these procedures should not be done through digital workflow? I don't think there's a single technique that one has that doesn't have some form of digital in it. I think the extent that you use digital really is up to you, but I think everything has to have some digital workflow. I think the days of you know, and when I talk about a digital workflow, I don't talk about a Panorex or a periapical, because I don't think that, I mean, even if it's a digital Panorex or a digital, I don't count that as a digital workflow. I think digital workflow would mean more CBCT, 3D, and things like that. Obviously, using all those kind of technologies. But the fact of the matter is that digital technology is not a thing of the future. Digital technology is already, I mean, we've been using it for 15, 20 years already. So there's you know, to now be working on a Panorex or to be working on a periapical and trying to make a diagnosis, number one, and then working out a treatment plan on that, I think it's actually getting to the stage where that would be considered malpractice, in my opinion. I think you cannot, and certainly what we teach at the academy, even from the most basic level, if you don't have a CBCT, somebody in your neighborhood has one. Use their CBCT. Go and find a place, a hospital, a clinic, or somewhere who has CBCTs and work. They're not going to say, no, you can't send them to me. They're making money. Of course they're going to use it. But every part of it, I mean, as far as I'm concerned, we do the digital workflow right from start to finish. And the case that I'll show you at the end, you'll see to the level, to the degree that we go into it, even for guided bone regeneration. But I don't think there's any case, and I don't know if you would agree with that. Would you agree with that statement? Do you think there's anything that can be done without digital?
Well, I think that's a great thing. You know, I'm the vice president of the Digital Dentistry Society, and we hold these meetings every year. And you know, we're you know, we know the work of Scott Gans and a lot of these thought leaders that have been talking about this for 25 or even 30 years. And I would agree with you that, you know, the idea of doing complex 3D bone reconstruction, or even I'm a bit even more dramatic, placing an implant without at least having seen a CBCT prior to that in 2020, now we're going into 2021, is no longer acceptable. I mean, I remember in my first days back in 2000, placing my first implants. I'd say between 2000 and 2004, because about 60% of my implants were placed just with a panoramic and a digital periapical X-ray, you know, measuring the thickness of the bone and going in with your heart pounding, you know. but we would outsource anything more complex and would send to a hospital and get back those big films. So, you know, a lot has changed right now, and I would agree with you that it's laziness, and I like what you said, that borderline malpractice to not use that technology. And how do you set up your digital workflow for bone regeneration in your practice? Like, what is the standardized workflow with your protocol?
Well, I think the first thing is, as you'll see from the case that we do, the first thing, it obviously depends on whether it's you know, on what type of case it is. And I think you know, is it just a basic case where it's a single implant, or does it require major reconstruction? Is there in the aesthetic zone? Is it in the posterior, etc.? You know, what sort of area does it require? Because each area will obviously get a different type of look. But essentially, one of the first things that we do with all of our cases, and often in the very first consultation, and I don't know if you agree with this, some people might not, but we will do a 3D CBCT right in the beginning, which will then allow us to make any determinations right off the bat. Is there pathology? Because we know how much better a CBCT is at determining pathology. How much bone is there? You know, what is the spacing? You know, and also if you've got the type of software that Carestream has as well, with the PDRP, the prosthetically driven implant planning, which I think is probably one of the most powerful tools, you know, at the first appointment, and not just powerful because you can diagnose, but powerful because you can blow the patient out of the chair. You know what I mean? Just by putting stuff in there, they sitting there like, oh my God, what's going on? This is incredible. This is insane. I've never seen anything like this, because the guy down the road was still looking at the X-rays, at the light. You know what I mean? And you know what I mean? Here you are putting in a virtual crown, putting in a virtual implant, showing them where the bone graft needs to be done, because you can see it's out of the bone, etc., etc. So it's such a key part of your sales process, and then secondly, your actual diagnostic, your major diagnostic process. So you really have a patient that walks out of there that's confident in your ability, and that is also confident in the process, because how do patients really know whether they need a bone graft? They don't. And if you're not utilizing these tools to say, if you look at where the implant needs to be in relation to the crown, can you see on the 3D rendering how it's sitting outside the bone, and we know we need certain amount of bone around that. This is why we need, you see the lights are all popping on, all the lights come on, and it's like, got it, yes, I need it. So, you know, it's made our sales so much easier. It's made the selling of a treatment plan, it's made the understanding, which is so key. And more importantly is that if you do spend that time doing it with the treatment from a medico-legal point of view, and you discuss complications, you discuss all that sort of issue, all of those become a big issue. And I'm sure, Miguel, how many times have you in the old days, you know, when you're starting out, you know, you get wiser, when you get older, you get wiser, and you start to talk about all the complications. And if I have this complication, this is what I'm going to do. If I have that complication, this is what I'm going to do. And when it happens, what happens? You don't have a sleepless night.
Not just that.
It's not when you what
I'm going to do. It's this is what I'm going to do, and this is how much it's going to cost. I'm not going into anything
Absolutely.
without all of that. That's actually one of the foundations of the slow dentistry,
Yeah.
which is signed valid consent. But you know, we got our first CBCT from Carestream back in 2008, and back then it cost $250,000. Only 1% of dental clinics in Europe had one of these, and I remember I tried to monetize it in the first day, you know, like to charge for the CBCT, and people were like, let me see if my insurance can cover this, and I was like, you know, just do it. And we've been including that complementarily in all of our first appointments, because it's a digital file, so the radiation is almost residual, but you get to see so much more. And the stitching, when it does the 3D rendering of the skull, as you say, the patient just instantly just, oh my God, you know, this is me. And you're completely right about using that as it's the ultimate patient communication tool. And quite frankly, we spend, before going into the dental chair, I would spend, you know, complex cases, probably 20 minutes with the patient, just showing them their own skull before we even sit in the chair. And the more you learn with this technology, it's like you can see everything there before you even sit the patient down from a bone reconstruction and implant perspective. Now, quick question. I once put that on a forum, and in the UK, dentists went crazy saying that it was overkill to suggest the CBCT prior to, at the beginning of every consultation. What would you say to that?
I think they need to catch up, to be honest. It's look, I mean, in South Africa, we have no issue with that. And, I think certainly one has to be discretionary around it. And I think one can't be cavalier and say in every case. So yes, there is. But I mean, the more I find and the more I see, it's insane. And I think, as time goes by, you see, I mean, I'm on my third Carestream machine. I started 20 years ago. I bought my first machine, was a Newtome 3G. It was the size of a room. And you talk about expensive. I mean, in rands, it was 2.5 million rand.
You see, and that's the hidden investment. Those are those hidden investments that nobody understands, that were a huge part of carving out your niche in the market. Because back that means 20 years ago, you were seeing more than anybody in your neighborhood. There's a reason
Absolutely.
why you were doing so much.
Absolutely. So, I think as radiation levels come down, and there's no doubt that they will, and as the algorithms get better and better, which there's no doubt that they will, and it's going to happen very fast, like Moore's law, better than anyone about futures and things like that. But it's gonna be insane, and I mean, it's going to be it's going to be something that's, what I mean, it will replace panoramics and periapicals to some degree, I think, with the technology the way it's going.
I usually say that, I said this in my Chicago lecture, in the last big one in the midwinter. I said that, it's going to be a short leap before artificial intelligence and the Internet of Things is talking to these technologies that we're working with, and they can very easily scan the post-op. So maybe the patient leaves us, goes somewhere else and gets scanned, and instantly, they have the right to their information, and artificial intelligence will understand if we did overreach or overtreatment or, did something wrong. So I think that, we really need to up our game right now, and these technologies are here to help us, but also to mitigate failure in the patient's benefit. I mean, look, I think it's going to make life a little bit harder for those that maybe were a little bit cowboyish, but it's really the most important time right now for people to learn more, to improve their skills, and to focus on ethical and science and evidence-based protocols. So, Howie, how do you think, how important is surgical experience in this digital workflow? So I guess the question is, how dependent should we be that this technology is perfect versus your traditional clinical experience?
I think the right answer for that is, or a good answer for that, before all the digital came through and we were working on panorexes and tomograms and all those sort of things and lateral cephs, and that's really all we had. Your skill sets really had to be very, very high. You had to be super skilled at every event, because when you opened up, a lot of the times what you saw is not what you got. And you had to be ready to, like, say, right, oh, no bone. Let me quickly, okay, now I'm going to harvest bone. Had you discussed it with the patient? Haven't you? Is the patient sedated? Can you have a discussion? All those things. So you had to make sure that you had all your skill set there. What digital dentistry, and certainly what cone beam CBCT has done for us these days, is that we can predict exactly what's going to happen, because we can see soft tissue thickness, we can see bone thickness, we can see bone quality, we can look at the anatomy from all angles, and we can see everything that we need to see. So before we start, as we mentioned before, we can sit down and we can talk every potential complication, every potential pitfall. We can give quotes for every single part, as you so rightly said. So because of that, I think it doesn't mean that we don't have to have the same surgical skill, but I certainly think that these days it's much easier because our planning is that much better than it was pre-digital.
So what you're saying is that for those that are just starting out with this technology, that you, thanks to a CBCT pre-surgical, you actually get to run each surgical procedure let's say in your brain or even digitally, and assess risk, potential outcomes, potential failures and costs, and share that with your patient. Because at the end of the day, it's not, you know, the problems aren't our responsibility, but the solutions are, you know. And I think that understanding the surgery and the science, even in the treatment planning, is very important.
Absolutely. I think, you know, if you just take the most basic of situation, placing a basic implant in a healed ridge, what is the bone quality? What is the density of the bone? How much cortex do you have? How much medullary bone do you have? Those are key factors which allow you, I mean, if you're drilling into type 1 bone, which is marble, it enables you to tell your patient that the risk of implant failure is higher because you're dealing with a very dense bone. If it's going to fail, this is what I'm going to do. I'm not going to charge you for the implant, but you'll charge a small fee for our cost for this and this. And if the failure happens, there's no loss of sleep. Whereas if you haven't looked at that, you haven't done all those things. I mean, you know, I've spent weeks not sleeping because of the fact that I've made some mistake that, you know, and sometimes even as an expert, you make that mistake because you drop the ball. But the advent of digital and the advent of CBCT especially has taken all those factors out and has enabled us so much to plan every scenario so carefully, you know what I mean, that it really becomes a wonderful part of our treatment.
Have you ever found yourself halfway through a surgery, getting a patient put a mask off and going to take an intraoperatory CBCT just in case?
Once or twice, yes, once or twice.
Yeah, you know what
I have to say that, but not often, because, and I think that's the key to the CBCT, is that it's not often. Look, when you get to key areas and critical things, without a doubt, there's nothing wrong. Go and do it, and I've done that once or twice myself, so without a doubt.
And that's one of the things about the guides that I think also help mitigate that kind of stress. So how important is knowledge and the ability to manage software and the experience with digital for you?
Look, I'm lucky that I'm very computer tech. I'm a very technical guy with software, so I'm lucky in that regard. But you know, I see problems with guys who don't have computer skills, and because they don't have computer skills, it actually scares them away from the technology. You know what I'm saying? And it's really something that one needs to actually be. You need to actually invest your time in training yourself, either, because YouTube is a wonderful teacher. You can learn anything on YouTube. But if you require formal training, go and get formal training from someone, because I think it is a barrier for a lot of people, and especially the older generation. Certainly the younger generation, you know, I mean, if I show my children what a CD, they ask me what this mini frisbee's for. You know what I mean?
You know, and you said it in the beginning of the discussion that, you know, you took this time to even have, you know, the humility to go and learn something new and how that changed your practice. And I think a lot of senior dentists watching this interview definitely should have the challenge themselves to go and learn even the basic functionalities of doing a surgical guide, because it definitely is the future. Now, with that, my friend, I'd like to see your, you said you've got this awesome case for us that I think it's going to be a world first.
Not the first time, the second time. Okay,
but I'm sure we're very, very excited to see this. You've always bring your A game. So if you'll talk us through this case, Howie.
Can you see my screen there?
Yes, we can.
Okay, so basically, obviously, what was asked was really about utilizing digital technology, and how do we actually utilize digital technology. And I think this case really epitomizes everything that we do right from the start. And I think everybody thinks of digital, when they think of digital, everything goes more towards teeth. And I think this is what this really is about, is that digital isn't just for teeth. Digital is for surgery just as much as it is for teeth. And I think it's absolutely key that we mention all of these things. I think just at this point, I just want to mention also Dental XP, which you know, has been a very important part of my upbringing and my growth in both international lecturing and local lecturing with Maurice, Salama, Henry, David Garber, etc. and Eddie Salama. But really amazing stuff. If anyone wants to go and work and learn some stuff, go to Dental XP, because it's a place you can learn a hell of a lot of stuff. But just to bring this case, this patient was referred to me with this wonderful temporary, and you know, she came from a different city in South Africa, and she came to me and she said, listen, I need to have new teeth. She had this failing bridge that was taken out. She had huge apical infections around the teeth, and she was really just generally unhappy with the aesthetics. And not only that, but this was a patient who was absolutely petrified. So the first hour of our appointment, she was in tears. Okay, she was in absolute tears right the way through the whole procedure. So the first thing we did at that appointment is we took our first CBCT, and so that we could get an idea of what we are dealing with, because until we do this, periapicals don't really give us the ability to look behind. How much destruction is taking place? What does it look like? And if we look at the area of the 1-1, you can see the massive vertical and horizontal defect that's coming there. If we look at the 1-2, we can see the large area that we've got there. So this allowed us to now say, right, there's active infection. We now have to get rid of that active infection. And once we've got rid of that active infection, we can start taking the case forward. The next thing that we do during the whole procedure is I work with the Carestream. I have the 3600 and the 3700. We work with our digital scanners. And obviously, again, this is not just something that we're utilizing as a gimmick. We're not utilizing this just for fun, and it's not something that's just for selling. It certainly is a mind-blowing experience for the patient when for the first time they have a digital impression. But not only that, but I now have the ability to take this case, work with my team, to take it with asynchronous consultations and move it around, and anywhere in the world, I can share this case with anyone that I want to and get advice on the kind of work that needs to be done in this case. The next phase is also the DSD, which is something that we do. The minute we're working in the aesthetic zone, we move to the next phase, and this is all dependent on our CBCT and our digital scan. You can obviously also work in an analog fashion. You can take improgum impressions or some kind of the high-end impressions, addition silicones, etc. And you can use that as well because they can be scanned by the lab as well. But these are the things this is the way we start all our cases and how we get to the case. And even before we start with all of the surgical part, we've already got our entire workflow, our entire work stream planned out to the nth degree, so the patient knows exactly what they're going to start with. And more importantly, when we move then to a lab-made temp, the lab-made temp is now fabricated and is working on the smile design that we created. These days we work with the Madrid DSD center. These ones were done with our center in South Africa, and the patient has already got what they started with. So before we even start, the patient already knows. Now, if you can understand taking a very, very nervous patient, a lady who's very concerned about her aesthetics, how important is that she understands, and especially somebody that was so nervous that was in tears for the entire hour, that when we put this in her mouth, her tears now were not for the anxiety, her tears were joy with hugs, and I cannot believe I'm on the road. The positivity that this created, because of the fact that she already knew what she was going to look like before we'd even started, is absolutely created the trust that we needed for her to be a real part of our team. And I think it's very important that we think of our patients as part of our team. You know, often we think of our team as the periodontist, the prosthodontist, the lab technicians, the oral surgeons, the orthodontists, but we forget that the most important part of our team is the patient. And if that patient is a good part of the team, more often than not, the treatment's going to be successful. If they are not part of our team, more often than not, we are going to fail. So basically what we did, we awaited 2 months for the soft tissue to heal in this case. We now come back and we do a new CBCT in this case, and we start to look at what's going on, and we can see that there's massive destruction of the bone. We've got 3D destruction, which we'll look at in a second. Now we start to look from our CBCT, we can see that we cannot harvest bone from the ramus because she still has bone plates from an osteotomy that she had. So we're now going to start looking at the situation where we are going to utilize the chin area, which is a nice area for us to harvest large pieces of bone. And the other nice thing about the chin is it also has a nice shape to it, which allows us to also recreate the shape for vertical and horizontal augmentation. So looking at the actual areas again, Miguel, how important is it that we can now see after 2 months, what can I expect? The last thing that I want to do is get thrown any curveballs at this time and not know what I'm going to do. I want to know exactly what everything looks like. I want to have that 3D rendering that allows me to understand the anatomy, that allows me to understand where are my incisions going to be made in order to make sure that it doesn't come over this area or that area where it could be dangerous for exposure. Do I need to do releasing incisions? Where are those releasing incisions? How many releasing incisions, etc., etc. And also, if I'm going to do periosteal releasing incisions, how high can I go before I run the risk of damaging nerves and things like that? So this is key information that really takes away a lot of the problems. Here you can see when we open up, what we get is exactly what we were expecting. You can see the massive, the releasing incisions that we made, direct releasing incisions that we do with autogenous bone. You cannot do these type of releases with any type of synthetic materials. They need to be further away from the graft, but with autogenous you can do that. You can see the massive vertical and horizontal defect that we're dealing with in this case, and the amount of grafting that we need to know where to go. Now you can imagine if I didn't have my CBCTs and I haven't told the patient, and I don't know that I've got bone plates at the back of the jaw. I first open the back of the jaw and I've got bone plates. I can't take bone. Now suddenly I tell the patient sedated or in general and under general anesthetic, what do? Go to the chin? I can't do that. I have to abort the situation. So we know exactly what's going on. The patient knows exactly where things are coming from. We've explained the complications associated with the chin. She knows exactly what's going to happen and what the risks are. So here you can see, I'm not going to go into too much detail, but the fact here with three-dimensional grafting using Curie techniques, and for anyone who wants to learn these, you can come to our academy. Also on Dental XP, they have online courses for anyone who wants to take them. And here you can see the three-dimensional recreation of bone using the chin blocks, etc. And everything inside here has been filled up with autogenous bone chips, which we know from Rick Miron is really the best quality bone that we have, because that bone is going to convert to new bone very, very quickly. We use PRF membranes over the top of the bone. And again, what is the key factor now? Now the key factor comes 4 months later when I'm going to place my implants. I need to know how much bone have I got left. If I look on the right-hand side, I think I should have built a little bit more, so I'm going to have to develop that bone a little bit more. But that also tells me what to expect for the patient. If I look on the left-hand side, you can see how beautiful the ridge has been created. We've got an absolutely wide 8 to 10 millimeter ridge. We've got enough vertical height. We're going to get a phenomenal bone in position. So now, again, the key factor is for me to now, at this point, take another CBCT. So I am now able to put my implants working with the PDRP, putting crowns in, which I haven't done on this one today, putting PDRP, putting crowns in, making sure I understand where everything's going to go, making sure that I can put my implants in positions that are going to be in the right position in bone, and not that I go off on a tangent, and make sure that that things are absolutely in the right place. So again, at this point, we go through another scanning process, because now the key factor is, how do I make sure that what I've planned, okay, is what I get? So in other words, if I put the implant, if I plan the implant on a CBCT, how do I make sure that that implant is in the right position? And the only way that we can do this is either through dynamic navigation or static navigation. And in these cases, we use the R2 gate system, which is a type of static guide. And the whole concept of guided surgery now becomes such a phenomenal way. And again, does it make it easier? Under certain circumstances, it can make it easier, but it certainly when you have the skill set and you understand the technology that you're working with, this takes so much of the stress out of the situation. I can remember many a time where I built beautiful bone, and when I get my angulation and I take the x-ray, I've exited out of the buckle because I didn't make sure that my implant was in the right position. Whereas with the technology, the guided surgery technology, it takes all that guesswork out of the situation, and it allows me to sleep a lot better at night. So here you can see we use guided surgery to get our pilot holes, and then obviously with the next stage we start to use osseodensification. Miguel, I know you're a big fan of it as well. Further developing the bone, and you can see what the bone looks like at 4 months. We really get absolutely beautiful quality bone, and these kind of cases show exactly why I love autogenous bone, because when you look at the bone, it looks like bone. It's hard, it's solid, it's beautiful quality, it's vascularized, it bleeds, it doesn't move. As you're drilling into it, it doesn't move. And obviously, the key factor with this Curry type graft is that you've got a very thin shell of autogenous bone, whereas inside you've got all that beautiful dense bone that we have, which gives us beautiful stability. Here you can see beautiful stability. I apologize for the photo on the right, which is a little bit out of focus, but you can see they're getting phenomenal stability in this grafted bone. And then once integration has taken place, we come back, and coming to the end of this case, you can see now we still have the soft tissue to deal with, and this is very, very critical. We're now starting to develop the soft tissue, and I think this is where most people fall short, and it certainly was the topic of my lecture, the AAID which is coming up. And really the whole concept of this case is development of the soft tissue, not just developing the bone, but developing the soft tissue. And in this case, we did a free gingival graft with a vestibuloplasty, utilizing a piece of material from the suture, creating the right shape, taking that shape into position, suturing it into position so that we've got good, decent, healthy tissue, which will then heal up. And there you can see 10 days post-op, how we've now started to develop a beautiful ridge with, obviously color's not an issue for her, but we're looking more for function than for form. And again, we don't have to worry too much about the pink, because this patient luckily has a very, very low lip line. And here you can see with the final, this is at placement of the final crowns, you can see a very good emergence, very, very good soft tissue profile. And I haven't taken CBCTs, we've taken periapicals, and when I see this patient at the next appointment, we will take CBCTs, because this is something that we finished very, very recently. But again, the key factor is that planning allows the execution to be seamless and effortless. And everybody says, you make it look so easy, it looks so simple. The simplicity is in the planning, and I cannot emphasize that enough, is that the more you plan, the more you understand the potential complications, the more you explain the potential complications. And as you said, I love what you said, Miguel, about the fact that you make sure they understand the cost of complication. All right, what does it mean? It takes all the stress out, and 9 times out of 10, you are going to have success. So with that, I say thank you very much. That was the case, the short case that we showed, and I hope you enjoyed it.
Howie, just to say that you absolutely, I mean, amazing, and you make such complex things look easy, and that is where I think people definitely need to come and train with you, because you can watch all the videos you want on YouTube, but you're not going to learn those skills. And I think that beautifully demonstrated the importance of CBCT in avoiding complications, and the fact that you went in every single stage of the game using your digital tools to understand exactly how to navigate complications and communicate with your patient and your team and get that impressive result. Congratulations. I'm sure people will learn a lot from this case. And Roberto, I'm going to pass it to you.
Thank you, Howie. Very nice case, very inspiring discussion before with Miguel. Thanks a lot for this. Now let me introduce you to my colleague Florina Demai, who is the product manager for our extraoral range in the EMEA region. Hi, Florina. How are you?
Hello, good evening, everyone. I'm good. I'm standing here in our showroom in Stuttgart, our headquarters in Germany. And it was very, very inspiring and interesting to listen to you and your clinical case, but also to follow the interview between you, Dr. Stanley, and Dr. Gluckman. Thanks so far.
I believe you have a couple of questions for our guest, right?
Yes, exactly. I had a lot of questions, but during the interview, I have to commit that you already answered a lot of questions. What I would like to still highlight, or basically ask for a summary, you mentioned that you started the digitalization process 20 years ago. What would you say? How did this move to digital technologies help you to grow your practice from a clinical, but also from a business perspective?
I think there were two arms. Firstly, I think it was probably the most disruptive technology that came about in all of my life as in the 30 years that I've been practicing. It's probably the most disruptive technology that there was. It has been a game changer of epic proportions. And Miguel, I'm sure you would agree with me. It has changed everything that we do. All our mindset, our understanding, everything has changed, and it is only grown in the 20 years that I've been using it. I mean, if I remember the images that I had, they were very poor. The scatter, the amount, you know, it really was hard to read them. They were tiny. You didn't have the type of software and the AI that and the interface that like CareStream has today. The easy, it's probably one of the easiest interfaces that we have to work with, and I've worked with many different softwares. So it became, even then, it became a huge thing, because not only were we running a business by providing a service to other dentists, so we already had a second business. That was already something that was big. But we were the only practice probably in Africa, or Southern Africa for sure. That's for sure, that had this one. Nobody else in the country had anything like it, and I know all our surrounding countries, no one had anything for probably 10, 15 years before we got this. And it was really, it was groundbreaking, because we used to use tomograms. I don't know if you even have seen a tomogram. It's just like, it's a horrible type of CBCT. We used to use a spiral tomography, where you had to hold these big things up, and you try little measurements. It was, I mean, we did it and we used it and it helped us, but it's just nowhere near. So it has helped tremendously in that the patients, as I mentioned before with Miguel, patient acceptance skyrockets, patients understanding and information and knowledge skyrockets, to the degree where their level of confidence in your abilities, as well as the profession's abilities, are absolutely staggering. And I mean, as I say, I'm on my third CareStream. You know, I have the 9600. It's my third one. You know, and you know, each time it just gets better and better. The technology gets better. The metal artifact reduction, the PDRP. I mean, each one of these things are just cool. And now with airway management and being able to measure the airways, and you see patients' eye, you know, it's just insane. And now I've got ear, nose, and throat specialists referring cases to me for airway. You know, can I check the airway for them? You know, I mean, it's just insane. So for me, it's probably also, if I look at it from an economics point of view, although in South Africa it's quite an expensive machine, it's probably been the most lucrative machine that I've ever bought, and still to this day it's the most lucrative purchase that I've made in my practice. Nothing else allows me economically to cover, and not only cover, but make money out of a machine than the CBCT does. Nothing compares. And I have pretty much every single tool that I need to do my job. You know, and I spare no expense. I have everything that I want, and that's out there. And this is the only one, I think. And Miguel, I think you probably agree with me. It's the only one that is viable economically.
Without a doubt. Just to jump in there, I would say that it's the entry-level technology. And again, I'd like to give a big shout out to all the engineers and software designers that work arduously, Florina, at your headquarters and around the world, because these guys seem to predict exactly what it is we need. And I have to say as well, the airway management as well, we just created a whole new department exactly thanks to the technology. It's almost as if you're predicting the future. So I exactly have to agree with Howie. An undeniably awesome tool for the modern practice.
Thank you so much to both of you. I need to add one thing. It's not just prediction, it's working together with high professionals as you are, and it's the feedback we are getting from you now for many, many years.
Thank you, Florina. Thank you for your questions. So please, Miguel, back to you for the final part of the interview.
Well, I could sit here and talk for hours with Howie, and I know he's the kind of guy that we could just break out some gin and tonics. I'm sure that's something that, and we could just talk for hours and hours about this topic, because, there's one of the amazing things that I've seen over time. And for all of those watching, make sure you follow Howie Gluckman's Instagram, his social media. So his institute regularly posts very challenging cases. Just 2 days ago, he put a case on asking people what they would do to solve this. And it's amazing how to see from all over the world, amazing surgeons argue and stuff. And of course, he's already solved the case amazingly. So Howie, just very quickly, what is your Instagram so people can follow you?
It's Dr. Howard Gluckman. And obviously the Implant and Aesthetic Academy is our academy. So either or, but if you just type in my name, you'll find me there. But thank you for plugging. I appreciate it.
No, not just that, man. Always learning amazing things, and also all of this work not only on Dental XP but also on your education platform. Correct?
Absolutely,
right.
Yes. So both platforms.
I'm going to spend this week. I promise you, I'm going to sit and learn something new today from you, because I think that it's amazing, and I just this case, it's now challenging me, and I want to learn how I saw something you did, and I want to replicate that myself. So anyway, I don't know if you know, but in 2019, Carestream Dental commissioned a global consumer survey in late November 2019. I actually got a chance to talk about this at the midwinter. This online study surveyed 7,000 nationally represented adults. So they were not dentists, they were people from the public across 7 global markets. And some very interesting results came out. So I wanted to ask you a little bit about your thoughts on the study. So the first thing that we learned was that nearly 74% of patients who reported a positive experience at their last visit said that their dentist or dental assistant shared information about the technology that they were using. And only 42% of patients reported a negative experience said the same. So 2/3 of patients treated recognized that they had a positive experience thanks to the technologies that were reportedly being used. What do you have to say about that?
I think, it makes so much sense to me, because the more we show technology and the more we share technology, patients have such a fear, but that fear is so ingrained of old technology. They kind of, if you're coming with that old injection to give, that silver injection, if you're still using that versus using a wand, or one of the electronic analgesic machines, just that, I've been using that for 25, 30 years since I'm also on my third one of those. Just that in itself is such a major technological advancement, where you've given the injection, they're like, have you injected me yet? What was that? You know what I'm saying? And that's that positive experience. That's another part of digital dentistry. It's a digital way of doing things. But the fact that when you start showing them technology and they're starting to say, hey, hold on, all my old fears, everything that I've had in the past has gone, because this is new, this is amazing, this is developed, this is like, everything's wow, everything's exciting. And also when you come in, I mean, I know, Miguel, you and I are very similar in that regard. We get very excited, and I mean, we are both very passionate about our jobs, and I've seen you with, when you talk to people, your heart is right on your sleeve, and you express everything. I mean, you talk with openness and honesty and things like that. And I hope I do a similar way with my patients. But when they see that, and when you're utilizing that technology and you're sharing it and you're saying, look at this, this is what we're going to do, this is how I'm going to do it. I mean, how can you not walk away from that feeling absolutely positive? And I think that's the key. And I see it every day in my practice.
I would agree 100%. I like to say that when patients come in, we spend so much. I have a poster on my lectures, a slide, and it's a very nice, expensive car, and over the sentence it says, it's better to have good technology in your clinic than in your garage. And the reason why I say that is because, not saying that it's not good to have a nice car, because I know you're a motorbike guy, you've got a beautiful motorbike that you drive around. But if we don't get to do what we want to do without this awesome investment in technology. So what I do when patients come to the clinic is I give them a tour and I show them all of the tools. And like Willy Wonka and the Chocolate Factory, just showing them, you know what this does, you know what this does. So by the time that they sit down in the chair and that we bring it out, they've already had that training. And moreover, they become a stakeholder in your business. And they feel that excitement, and they feel that they're part of the business. So it's like, instead of having a client, now you have a partner. And I think that that's one of the extraordinary things that technology does. And it's so much fun to share. So I would agree with you wholeheartedly. And I think the fun thing about this CareStream study that came out is it's an inevitable tipping point, showing that, and Christian, you mentioned Christian regularly, he always says, digital doesn't make you a better dentist, but no. It's definitely going to, and you touched that as well, you have to have the surgical skills, you have to know the science, you have to know the evidence. Self-driving cars are coming, but you're still going to have to learn how to drive, and you have to have a driver's license to have one, just in case things break. But it's inevitably, I mean, it's not part of the future, it's already part of our past. You've been using it for 30 years, which is commendable. Honestly, I did not know that, and it explains a lot. You were an outlier in Africa. I'm sure you're probably the first in Africa, and it's absolutely impressive, my friend. And I really commend you for that, for your drive, for your ambition. And we've got the Slow Dentistry Foundation, which is a non-profit based in Switzerland, and will be coming out in 2021, because there's 4 very basic cornerstones, which you and I have discussed, which are very, very simple, require no technology. But for those that are using technology, we're having a digital badge, which will be unlocked soon. And on that digital badge, we'll have also 4 cornerstones. And one of them will be to never do an implant or complex bone reconstruction without the aid of a CBCT. And so
Absolutely,
we're bringing that out. We're bringing that out basically, and that all of the marketing of slow dentistry is to the consumer, and no longer, hopefully in the future, will people with problems like that woman that you helped, you've changed her life. It wasn't magic, it wasn't marketing, it wasn't a good design or good promotion or a good Facebook page that saved her. It was your ethics, it was the investment you made in technology, it was slowing things down, studying this with your team, understanding, reverse engineering that smile into understanding where the bone, but having that, that love for her, for the case, for the profession, for the craft, making that investment. You've got a big family, and yet you still make that investment in excellence every single day. And that decision is the decision of greatness, my friend. And that's why you deserve to have your name up on the lights, man, because it's absolutely amazing what you do.
Thank you, buddy. Thank you so much.
So I'll leave you with one last question. Having said that, is now the time more than ever to invest in these digital technologies for practices? And let's focus this on your community in South Africa.
I think there's no doubt. I think the technologies are getting cheaper and cheaper. Obviously, we are early adopters, and sometimes you know, even earlier than earlier adopters, both you and I. But you know, we well past that, and I mean, you know, the technology is not, it's not technology of tomorrow, it's technology of yesterday, and we are already in 3rd, 4th, 5th, 6th, 7th generation in some of the technologies, and you know, it's cost effective enough. CBCT, I think every practice should have one. I don't think any practice should go without one. You can get various sizes, and you know, you can get one that matches what you do. But I mean, even looking at endodontics, looking at, you know, anything that you do, it is just absolutely, even if you're doing a little bit of orthodontics, I mean, is the bone there? Is the bone not there? Can I move the tooth into that space? Can't I move the tooth into that space? That's a topic that's been spoken about way too much, you know what I mean? And you know, as a periodontist, we see the fallout from those cases where things were moved out of the envelope, and now you're dealing with an issue. So everybody should get on board with that, and you know, there's no excuse. I think the scanner certainly is, the intraoral scanner, you can maybe put that as a second. The CBCT, in my opinion, is primary. And as I said, it is the most disruptive technology that's ever been brought into dentistry, in my opinion. The intraoral scanner is the next one that's big. And again, all these things are getting cheaper, and you know, they're coming to the party. And I think it's you know, get on there. It's just, you know, also just, it's so exciting because it makes your life so much fun. I mean, I still love picking up, you know, my staff can do the intraoral scans, but I love doing the intraoral scans. It's just so much fun for me. I put on a little bit of cool music so that it plays with a little bit of, I think Dave from the UK taught me to put on Star Wars music.
And you feel like Luke Skywalker.
This is cool. Yeah.
Thank you
Epic.
so much,
So
Howie.
thank you very much.
Thank you so much. That was inspiring as always. I miss hugging you. I miss your stage presence, but I think you carried it today. Amazing. Roberto, back to you, my friend.
Thank you, Howie. Thank you, Miguel. Thank you, Florina. It was another fantastic topic, very inspiring discussions. Thank you to the audience for your participation and questions. And let me remind you to please register to see the remaining interviews. Tomorrow night's topic will be full digital implant prosthetic rehabilitations with Dr. Henriette Lerner. Good night, and please stay safe.
Thank you, guys. And if I can just say thank you very much from my side, Miggy. You know, you're a dear friend, and it's always a pleasure talking to you. And your passion and fun and thing, it's just amazing. So thank you for the interview. It was a lot of fun. I absolutely loved it. And Roberto, thank you for organizing it, and to Carestream and to everybody behind the scenes who did it. Thank you very much. It's wonderful. And I can certainly give a shout out Jafar, who lectured last night, and to Henriette, who's just an insanely brilliant surgeon. You have to see it. So thank you very much for the invitation. It is a huge honor to be here with you. Thank you.
Thank you, Howie. It was our honor to have you with us. So thanks again, and good night.